So, good afternoon, everyone. Today we are discussing the most common deficiency, vitamin deficiency in India, that is called vitamin D, and it is associated with a lot of number of disease recovery, and especially important for our immunity. So, what I am Dr. Abhijeet Khandelwal, professor in Department of TB and Chest, Index Medical College Hospital and Research Center, Indore. So what we are going to discuss in the next few slides is the role of vitamin D and the associated comorbidities. So I'm going to discuss on the background of vitamin D basic, epidemiology, cause of vitamin D deficiency, vitamin D beyond musculoskeletal health, cardiovascular health, diabetes mellitus, role of immunity, vitamin D and nanotechnology, update on the scientific data on the vitamin D in nano formulation. So if we go for the basic, this is a beautiful diagram which is showing for the lungs, breast cancer, grip strength, bone health, blood pressure, allergies, sun exposure, prostate cancer, and falls. So it is a complete nutrient for the whole body. You can go through the detail on the slide. We will wait here for the 10 to 15 seconds. So, do the Indians have the sufficient level of the vitamin D? Answer is no, because up to the near about the 76.9 millions Indians or 76.9% Indians are the insufficient vitamin D level. So highest incidence of the vitamin D insufficiency is the age group is 18 to 30-year of group, and the insufficiency is marginally higher in males than compared to the females. So the diet increase melanin content of the skin, inadequate sunlight exposure, or the fortified food contribute to all the vitamin D deficiency in India. The conversion is the 7D hydroxy cholesterol to the 25 hydroxy D3 from the skin to liver, then liver to kidney, and then from kidney to bone, the 125 hydroxy D3, increase mineralization, increase absorption of the calcium. And dietary are the basically the dairy products and the fish, and mainly through the sunlight, and the vegetarian non-vegetarian sources, only vegetarian source in the sun exposed mushrooms. Vitamin D fortified food available in the Western country but not in India. Key role in the calcium metabolism. The causes of the vitamin D deficiency is the ultraviolet B related deficiency, advanced age, dark skin, usage of the sunscreen, season, latitude. Medically, physically condition related to deficiency is the fat malabsorption, drug-induced liver and the chronic kidney disease, obesity, and smoking. Signs of the symptom of the vitamin D deficiency is the Walding gait, proximal muscle weakness, anterior tibial tenderness, rib cage tenderness, presentations with fractures. The symptoms are the isolated or generalized ache and the pain in the bone and the muscle weakness, difficulty in squatting, standing, walking, and more frequent fall. So the vitamin D level, if we see from the unit of the nanogram per ml, less than 20 is deficiency, 21 to 29 insufficiency, more than 30 is sufficiency, as per the Institute of the Medicine Committee, Endocrine Society of the Clinical Guideline. The subclinical level is defined in the 25 to 75. Serum 25 hydroxy D level is preferred, longer half-life of for about 3 weeks, stronger affinity to D binding proteins, higher blood concentration than any other metabolites, represented the convergence of the all form of the vitamin D. Method for the immunoassay like radioimmunoassay or chemiluminescence, commonly used in India. Can't difference between D2 and D3. HPLC is the good accuracy with lower cost. Liquid chromatography, mass spectrometry is the gold standard, but not available widely. So the next layer, next overview is the vitamin D beyond musculoskeletal health. For example, hypertension. So vitamin D deficiency can result in the hypertension via RAS pathway, effect on the vascular endothelium, role of the parathormones. You can go for this slide, how the renin gene convert into renin, then angiotensin 1, ACE1, ACE2, angiotensin 2, AT1 receptor, ARB. It's a steadily increase in the plasma renal concentration across the decline concentration of the calciferol. Study done in the Lyric study of near about the more than 3,000 subjects. The reported significantly higher angiotensin 2 level in the patient with vitamin D insufficiency and deficiency as compared to those with the sufficient vitamin D level is a potent suppressor of the renin gene expression, leading to the decreased renin production. Vitamin D has demonstrated the beneficial effect on the vascular endothelium via vitamin D effect on the vascular endothelium via the vasoprotective effect and additional action. Vasoprotective means reduce effect of the advanced glycation end product, increase release of the activity of the nitric oxide, reduce pro-inflammatory and pro-atherosclerotic cytokine, and the growth of the vascular myocyte, enhance the prostacyclin production. Is the open label study in the 23 patients with vitamin D deficiency to evaluate the effect of the administration of the 3 lakh international unit per month in the parameter of the endothelial dysfunction. You can see the FMD score for the deficient group was significantly lower with the compared with the control group. The values are significantly higher after the treatment compared with the baseline and the control group. Level of the TBARS were significantly decreased after vitamin D treatment compared with the baseline and the control group. Leptin level were low before treatment compared with the control group and significantly increased after vitamin D therapy. You can see the increased peripheral vascular resistance, increase in the blood pressure, increase in the parathormone, pro-stimulatory effect on the vascular smooth muscle cell via the changes of the calcium flux, release of the endothelium, the query release of the renin. This is the trigger the secondary hyperparathyroidism. This is the FUSE study, which is showing the vitamin D deficiency and hypertension. The summary is the NHNE's study 3, third National Health and the Nutritional Examination Survey. Gurgaraz A and the colleagues, Chandana SR et al., Menar E et al. All are the cross-sectional meta-analysis and the cross-sectional and the retrospective. Sample size, one is the more than 12,000, next is the more than 78,000, that is the 155 and the 547. They found that the significant inverse correlation between the blood pressure and the pulse pressure and vitamin D level, the calciferol was observed. Prevalence of the hypertension in adult in US was 30% higher patient with a low level of the calciferol. It's inversely associated with the hypertension. 25 hydroxy D was significantly lower among the hypertensive and the normotensive subject. Hypertension is associated with the 8-time increase the risk of the CAD in the presence of the low vitamin D regardless of the gender. Vitamin D beyond musculoskeletal health, and the scenario is the type 2 diabetes mellitus. So the pathophysiology of insulin resistance and type 2 diabetes mellitus in vitamin D deficiency. It contributes the insulin resistance and the development of the type 2 DM via the two mechanism: direct effect, decreased binding of the vitamin D receptor, indirect effect with the aberrant calcium flux. You can see on this the flow chart how it affects the lipoprotein lipase level, aberrant calcium flux, and the other possible pathway. 15 से 20 मिनट लगेंगे. Molecular mechanism of the vitamin D deficiency and the development of the insulin resistance. You can see the impaired pancreatic beta cell function, impaired insulin signaling, and impaired hepatic lipogenesis and the gluconeogenesis, and impaired cellular bioenergetic via impaired mitochondrial function, altered calcium flux, reduced expression of the insulin gene via CREB, decreased activation of the PPAR delta, indirectly via increased PTH and the altered calcium flux, RAS pathway activation. High magnitude of the overlap between the vitamin D deficiency and type 2 diabetes mellitus and hypertension necessitates the need to the routine screening and effective management. Found that the percentage incidence of the vitamin D deficiency, they found that the prevalence of the vitamin D deficiency was higher in the newly diagnosed cases compared to the already diagnosed cases in the all three cohort. And preferred frequency of the dose was once in a week. Out of the 12 under 57 patients, 84.8% received the vitamin D supplementation. Preferred dose and the route of administration was the 60,000 international unit and oral. This was a cross-sectional observation pan-India study across the 29 sites enrolling the 1501 patients with type 2 diabetes mellitus and hypertension. This is the oral vitamin D supplementation of the 60,000 units per week for 8 weeks significantly improve vascular function in type 2 diabetes patient and vitamin D deficiency. And the 75 patient found to have vitamin D deficiency level is less than 20 nanogram. Vitamin D supplementation of 60,000 international unit for 8 weeks given. And its supplementation improves the vascular function, reduce in the oxidative stress, the arterial stiffness index, carotid femoral pulse wave velocity, brachial ankle pulse wave velocity, reduction in the serum melanoidal height level, and the rise in the total antioxidant status. There are the other few studies in the vitamin D deficiency and the diabetes mellitus. The Pelage S et al., Mehta N et al., Brijesh M et al., Kumar H et al. The designs are the retrospective, prospective, and the prospective. The sample size is the one is the 4,628. Next in the 100 diabetic, next in the 150, next in the 50 diabetic patient. 86.4% diabetic patient are vitamin D deficient and insufficient. 87% of the diabetic patient are vitamin D deficient and the insufficient, and the low hydroxy D is observed in the diabetic patient. As the vitamin D deficiency worsens, so did the diabetes control. There was the high prevalence of the vitamin D deficiency in type 2 diabetes mellitus. Vitamin D level were inversely related to the HbA1c, that means inversely related to the glycemic control. So section 2, vitamin D beyond musculoskeletal health, the role in the immunity. Recent evidence to point towards for the improving immunity, thereby the prevention of the death, and the enhancing the physical barrier to the infection. Vitamin D level moderated the adaptive immunity, enhancing the cellular immunity. Maintain the space junction between the cell, forming a barrier to prevent entry of the microbe. Increase the production of a natural antimicrobial molecule and reduction of the cytokine storm. Suppression of the inflammation and the autoimmunity by reducing the production of the inflammatory chemicals. And the role in the case of the immunity, it might play important role in reducing susceptibility to microbial infection, so all the UTIs, RTIs, and the TB. Vitamin D deficiency also might help improve response to the vaccines and the vaccine-mediated immunity. It may help modulate the immune response, thus providing the beneficial effect in the autoimmune disease like the rheumatoid arthritis and SLE. In the infections and the immunity, Consistent association, the low serum concentration of the 25-hydroxy vitamin D and the susceptibility to the acute respiratory tract infection. Its several immune pathway net effect on the boosting mucosa defense and suppressing the excessive inflammation. 25-hydroxy D induction of the antimicrobial peptide in response to the both viral and the bacterial stimuli, suggesting a potential protective mechanism against the respiratory pathogens. This is the vitamin D role in the infections and the immunity. D is the cellular immunity and the adaptive immunity, increase cathelicidin, suppress of the cytokine storm, suppression of the inflammatory cytokine, direct microbial toxicity. Is the correlation, the seasonal influenza peak in the winter as solar UV and 25 hydroxy concentration are lowest. Pneumonia higher, vitamin D concentration leading to the reduction in the cytokine storm. These are all the mechanisms to reduce the bacterial and the viral infections. Supplementation should be started or increased several months before winter in order to raise 25 hydroxy D concentration to range necessary to prevent acute RTI. The optimal level of the 25 hydroxy D appear to be in the range of the 40 to 60 nanogram per ml. D is the 10,000 international unit per day for a month has been indicated to be effective in rapidly increasing circulating level of 25 hydroxy D in the preferred range of the 40 to 60. To maintain the hydroxy level after the first month, the dose can be decreased to the 5,000. This is the treatment of the deficiency. The first option is the weekly dose followed by the maintenance. 60,000 units weekly for 8 weeks, followed by the maintenance therapy is the once a month or 1,500 to 2,000 units per day. Continuous monthly therapy is the 60,000 to 1,20,000 per month. Daily is the 2,000, near about the 2,000 international units per day. Parental is the measure the serum level after the 3 to 4 months. If level not adequate, then repeat the dose after the 6 months, the 6 lakh unit. The recommendations, if you go for the recommendation, the story is that considering the typical 25 hydroxy D level in the most Indian study have been found to be between the 4 to 15 for Indian, and upper end of the above recommended intake may be appropriate. The 1,000 unit daily for the low risk adult less than 50, 2,000 for the high risk adult, high risk and the older adult. The toxicity has not been reported if the intake of the more than 10,000 international unit per day. The common oversight in the management to stop treatment once the sufficient level of the vitamin D get, need to continue maintenance therapy, especially in the high risk group, to ensure the optimal level of the vitamin D. Maintenance therapy is the 1,500 to 2,000 international unit or 60,000 international unit in adult for the more than 18 year of recommended by the following guidelines: the Endocrine Society, AME, and the Italian chapter guidelines. So what is new? New is the nanotechnology and vitamin D. The nanoparticle are the colloid particle that ranges size between the 10 to the 1,000 nanometer in diameter. A first time in India, novel drug delivery system comprised of the nanoparticle is less than 150 nanometer in diameter, stable even in the harsh GI condition, ready to absorb formulation. Absorption does not depend on the lipid or the bile site. These are the key feature of the nanoparticle therapy. Vitamin D encapsulated in lipid nanoparticle with the hydrophilic surface is based on the vitamin D nanoparticle technology. Diameter of the less than 150, pre-solubilize in the lipid, reduce the need of the dietary lipid. Nanoparticle reduce the dependence on the bile salt for emulsification and micelle formation. Is the structural integrity is in a strong acidic and the bile media, representative the fasting and the fat state, ready to absorb micelle-like formation. This is something busy slide for the fat globule, fat droplets, for the emulsions, the micelle formation, the vehicle lipid, the vitamin D in chyme. The prerequisites of the current available vitamin D formulation is the dependent on the lipid for the solution, is dependent on the bile salt for the emulsification, and dependent on the bile salt for the forming the hydrophile micelle. But in the NDDS, the no need of the disintegrates or dissolution, absorption, not depend on the lipid, not depend on the bile salt, of the micelle formation, promote absorption of the vitamin D across entire small intestine, promote the intestinal absorption through the multiple pathways. So the micelle is finally, the NDDS is the ready to absorb micelle-like structure. So it absorbs the path by the pathway. They are improving the bioavailability, the transcytosis pathway, mucoadhesion, paracellular pathway, passive diffusion, and for the conventional D3 formulation absorption only with the passive pathway. This is a huge study, absorption study of the nanoparticle-based novel drug delivery system for the vitamin D using the inverted intestinal sac technique. And they conclude that the absorption of the vitamin D3 in the NDDS is a 90% various segment of intestine. And the D3 in NDDS is the non-specific absorption throughout the various segment of the rat small intestine with the high flux permeability coefficient, and the percentage of the absorption. Average absorption of the vitamin D3 was near about 77 to 8% through the rat small intestine. The predicted human absorption may be more than the 90%. So the nanoparticle-based vitamin D formula is highly effective in normalize the vitamin D level than compared to any conventional available option. This is the prospective open label non-comparative dose response study in the 43 patients with the vitamin D deficiency. 84.2 patients shows the improvement within the 4 weeks of the therapy. And the patient assessment excellent to good response by the 97% based on the tolerability of the therapy, improvement of the physical component, and the improvement in the mental component. These are the micelle cell formation in the achieving the higher level of the serum, and there is a then the observe that the similar dose of the fat soluble vitamin D3 level, open level of the pilot study in the 180 healthy school children, 2 different formulations of the vitamin D3 administered once a month for the 6 months, 60,000 international unit fat global vitamin D orally with the milk and with the water. The significant greater increase level in the group as the B as compared to the A. So it can be easily absorbed with the water also. So the diet increase the melanin content of the skin, inadequate sun exposure, and the lack of the fortified food contributes to the high vitamin D deficiency in India. Vitamin D deficiency has been indicated in the development of the hypertension, type 2 diabetes mellitus, increased susceptibility to the respiratory infection. Recent guideline maintain the therapy of the up to the 2,000 unit or the 60,000 once in a month after the treatment of deficiency. Nanoparticle formation is the ready to absorb and the high biological form of the vitamin D deficiency. This is all about the vitamin D deficiency. You can go proceed with some beautiful slide. And if you have any questions, then I am happy to answer. You can raise on your chat box, or you can write on the chat box, or the raise your hand. Or the showing the deficiency and the beyond the musculoskeletal. These are the common causes of the deficiency: the fat malabsorption, drug-induced liver, chronic kidney, obesity, smoking, advanced age, dark skin, usage of sunscreen. Okay, Chahat, we can close this session.
Okay, sir.